Sure, let's do this one. Do you want to kick us off or what umbrella?
I have no strong opinions this evening.
Well,
Yeah,
let's open up the meeting because it's a small meeting and with a modified agenda because unfortunately the person who was going to do a case presentation this evening had realised they had a conflict in their calendar and so they're not able to attend. But Patty and I, we toyed with the idea of, what to do, but we thought it'd be worthwhile still to catch up and use it as an opportunity to get to understand the context of your work and what you want to get out of these sessions and thinking about into next year, given this is our last session for the year. But just to start off by acknowledging country, I would like to acknowledge the traditional custodians, the Wurundjeri and Burrong people of the lands that I'm speaking to you from today. We also acknowledge the traditional custodians of the various lands on which you are zooming in from today, and I pay my respects to elders past and present and emerging, and as well as any First Nations people who might be participating in our meeting today. So given we are such a small meeting, what if we just go around the room? Oh, the other thing I should say, Sophie from Search has opened up the meeting and it is recording. And Sophie will be here to let anyone else in for another 20 minutes or 10 minutes, 15 minutes or so. But other than that, there's no admin. Hi, Sophie. Thanks.
Because Sophie's got a conference, so everybody's got something else on. I think today is one of the issues with it.
Yeah. And I'm also aware that, for many of us, it's the last week of November and there's numerous meetings, network and other meetings scheduled in the last week of November just to try to clear the calendar of meetings in for December.
So maybe if we just say to you what we've decided to do with a modified agenda, and then you can be thinking about that as we go around the virtual room. So we were going to have a presentation from Kath Bateman down in Gippsland tonight, illustrating some of the issues around the increasing incidence of syphilis, and just to illustrate the wisdom behind the latest guidelines, which indicate that we should be thinking about screening syphilis much more frequently than we have been in the past, and repeating it during pregnancy, but also thinking about it for women who are not pregnant. So thinking about it for our IUD and Implanon and general contraception discussion patients. But unfortunately, Kath has double booked herself and isn't able to do the case history. So while we're going around the room, if any of you wanted to share a case that you've either had recently or heard about of a patient with syphilis, we're happy to do that. Otherwise, I can talk about one that surprised us all recently and illustrated a point. And then we thought what we'd do was we would start by going around the virtual room and seeing what's happening in your local areas, and if any of you are new, to introduce yourselves, of course. And then we thought we could share a little bit with those of you who weren't there yesterday about what happened at yesterday's Hubs meeting, which was with the Department of Health, which was interesting. Carolyn will, as always, give us a bit of an update on what's happening around Victoria and her upcoming report. And then we thought we'd do a little bit of a deep dive at the end about what are our priorities going to be as a community of practice network going forward next year. So we'll be really interested to hear some ideas from you guys about that. So maybe if we start by going around the room.
What if I just call out your name?
Yeah.
And then how about we start with you, Carolyn, if that's okay, and then Purnima.
And you have to explain your earrings to the group because I think they need to be explained.
I'm close to the camera to see. It's a naked person and they're mirrored. And so I walk along the street. One is silver and one is gold. I walk along the street and I'm just reflecting light at everybody, and nobody realises that it's nudity that's being reflected upon them. So they always get a bit of a comment. But hi, folks. Thanks, Kath and Patty. My name's Carolyn. I'm the manager of the 1800 My Options service at Women's Health Victoria. Thank you.
And Purnima, then Ian. If you can, Purnima. Hi.
Hello,
Hi.
I'm Purnima. Can you hear me?
Yes.
I work as a GP in Bendigo with special interest in women's health.
Thanks. And you're in a private GP clinic now, Purnima, aren't you?
Yes, I'm in private.
Yeah.
So do you work at the hub as well, or?
No, not anymore.
Oh, okay. But you're doing the good work in the GP practice. And I just didn't catch which practice it was.
I work at the Stratdale Medical Center, which is in Bendigo itself. I'm still in Bendigo.
Yeah. I still didn't hear it.
So I'm at Stratdale Medical Center, which is in Bendigo.
Okay, okay, cool,
Fantastic. That's great.
Cool. I saw your face before. Would you like to?
I was just I'm driving too, so I just unmuted myself.
Okay.
And,
Thanks.
yeah.
And so, Ian, your face briefly shot on. If you could show us your face again and say hi. Mm-hmm.
There he is. Oh, that's Louise.
Yep. Okay, so I'm up in Mildura.
Hi, Ian. What's your role up in Mildura?
I'm one of the obstetricians up there.
Oh, okay, great.
But I provide a MSET service to Broken Hill.
Uh-huh.
This is Ian Pettigrew.
Yeah. Okay.
Yeah. Well, it's very nice to see you, Ian. And I think people are moving across the screen a lot. I think I've got Angie Reid there. I can see you
Yes.
driving, Angie.
Hello, driving. Sexual reproductive health GP, Coburg, Melbourne.
Coburg, yeah.
Okay.
Do you work at CoHealth, Angie?
No, I don't.
No, you don't. Okay, sorry.
That's all right.
Good. Nice to see you, Angie.
Thank you.
You're a private GP practice.
Yes.
Yeah.
Yes.
We won't distract you if you're driving.
And Louise?
Oh, you're on mute, Louise.
Oh, it's not working. We might come back to you, Louise. Yeah.
And Sarah, then Kylie.
Hi, I'm Sarah. Work at Sexual Health Victoria, the nurse practitioner candidate there at the moment.
Sarah, hi. Nice to see you.
And I've successfully got my little one into his pajamas, so I'm
well
winning
done.
so far.
Yeah, it's a funny time of night, isn't it? Yeah.
It is.
Thanks for juggling what you have to do.
I'm back again.
Hi, Lou.
Oh,
Hi, sorry, I've got no internet at my house. I'm on the phone.
And you just dropped out.
yeah, she stayed in one spot.
Sorry, Lou, we just can't hear you. It's terrible, isn't it? Why don't you turn your camera off? Proves it.
Okay, all right, I'll try.
No, there, we can hear now.
Yeah, but it's moving a lot, so maybe that'll be better.
Oh, God. Well, I introduce you, Lou. Do you mind? So, Lou Holland, I know you as, is the nurse practitioner up at Bendigo Community Health Service. Thanks, Lou. And Kylie, would you just like to introduce yourself? I don't even know where Kylie works. I think it's community health. I know Kylie's a midwife and she works in community health, but that's all I know.
But
I can say she works at Sexual Health Victoria and she works at the Northern Abortion Sexual Health Services. If it's the same Kylie.
she works
Oh.
with Kate Chowkey, maybe,
Does she? Oh, does she? I didn't realise that.
and she works with you too, Sarah, does she?
Yeah, a couple of days a week.
Oh,
If it's the same Kylie, but Kylie, please jump in and tell me if we're wrong.
I think that might be all of us, is that tonight?
Hello, I'm sorry, I've just pulled into my driveway. So yes, it is Kylie from SHV, and I also work at Northern with Kate Chowkey. Yes.
Yeah.
fab.
So maybe we'll go to you, Carolyn, to give us a little bit of a rundown on what's happening on the database front and the callers that we are here to look after.
Thanks so much, Patty. I feel like a bit of a broken record on this, but we're really busy. I keep on thinking that busy is a thing and then we get busier, and so it doesn't seem to stop. So this month we're currently averaging about 35, 36 calls a day to the 1-800 My Options phone line. 90% are looking for an abortion. And that's, I think, for context, last year in November we were getting about 30 calls a day. So it's an increase that's notable for us on the phone line, particularly when the system continues to be a little bit wobbly, particularly for underserved communities. So most of the people that we speak to, close to 50% have a healthcare card or pension card, and about 40% currently are saying they can't afford to pay for sexual and reproductive health services. So it's very difficult to find accessible and affordable services for our callers at times, particularly when they come from rural and regional areas. So we are preparing for things to continue kind of at this rate through the rest of the year, and January is normally another really busy month. But from our systems point of view, the system is managing pretty well at the moment. Wait times across the system are not too long. We've almost got 800 clinics on our database, which is huge, coming from 30 back in 2018. So it's really great that more clinicians and more services are willing to be associated with abortion and contraception and sexual health. I think it's really heartening to see that despite a lot of political rhetoric that's harmful and frustrating and negative and misleading, stigmatising, we've got this amazing system and healthcare providers that are standing up and not ashamed to provide these services. So thanks everyone who's doing that in the group. Some of you might have also noted, I'm just going to flag, we released a report on the first 5 years of 1-800 My Options data last month, and it was in the media a little bit. We've also got a webinar on this Thursday. I can drop the details in the chat so that if anyone wants to attend, they can do so. You'd be very welcome. It's a really useful report looking at the 1-800 My Options caller data, but also sitting that alongside PBS and MBS data and CFIR data to look at the ways that disadvantage and age and various other characteristics impact on people when they're calling our service. And what's really sobering about the data that we have is that it's really demonstrative that people who are from underserved and disadvantaged communities are more likely to call us over 9 weeks and are more likely to be experiencing multiple barriers to their care. So while the system is doing great and we've almost got 800 providers on our map, there are still significant barriers to access. Also on syphilis, I was just looking through my inbox just now because I'm on a syphilis action plan steering committee with the Department of Health. We've been
tell us what that involves.
Well, not a lot, because we've only had one meeting this year, which is frustrating because, you know, syphilis isn't going anywhere. And so I am on a steering committee for the Syphilis Action Plan, and we're still waiting for this to be published. And it's meant to sit alongside the BBV STI plans that were published I think last year or the year before.
Mhm.
I'm not quite sure what the issue is in terms of why it's not been published and why we're not hearing much about this at the moment from the department, apart from potentially something around them just being a little bit slower. So the last meeting I went to was in June, and they were reporting at the time that there'd been no congenital syphilis in Victoria so far, or to that date this year, but I'm not sure what the stats are saying since June. That's all I've got to report on that. It's not very interesting, actually.
I attended the recent College of ONG ASM in New Zealand, and there might not have been any reported by June, but there has been a case since then. And there's definitely a big uptick in the number of congenital cases across Australia and New Zealand.
Yeah.
And you know, the intersectionality of all the disadvantages coalesces in the groups that are experiencing really increased rates of syphilis.
Absolutely.
In women of childbearing age, and often picked up only in pregnancy. But also I went to a really good talk where they presented several cases where patients had been screened in early pregnancy but had developed either unusual rashes or febrile illnesses, had presented to healthcare in the second trimester. Syphilis had not been thought about, and congenital syphilis was picked up in the infants. So they really, the sexual and reproductive health experts were really pushing two screenings for syphilis, and also really encouraging during pregnancy, and also really encouraging us to think about women of reproductive age. So in all of our interactions with them, maybe it's a discussion about which type of IUD they're going to have, but to think about repeating their bloods and to do their syphilis serology as well. And to think about syphilis and its unusual presentations. And the acknowledgement was that we haven't grown up with syphilis as, an Anglo-Saxon based medical school graduates and nursing graduates. We haven't thought about it. We haven't had to think about it. And we really need to think about the various presentations of syphilis. Huge overrepresentation in Māori and Pacifica, overrepresentation, of course, in our Indigenous communities and refugee communities. The other thing they were really strong on, if they were singing from one songbook, it was there is no place for making decisions about who to screen in terms of high-risk communities, that the days of thinking you'll screen high-risk communities alone and our ability to decide who's high risk. So to think about it for all of our patients. It was the data was really sobering, actually.
Absolutely. And I believe that the Syphilis National Action Plan might have been updated, but I'm not sure about that because of this is an interjurisdictional issue across the country that we are seeing.
There is a good website that we could share with everybody. Everybody probably knows this website. We can share it with you. I'm just trying to share the screen.
Yeah, there's that one. Yeah, so we looked at the Australian STD management guidelines,
which are easily kept on your computers as a favorite, or you can download. But that's the most up to date that we could find. So just to encourage people to have a look at that.
I can put that in the chat, actually.
Incidentally, has anyone got, before we move on to anything else, has anyone got a case that they wanted or could mention that of an incidental screening that brought up a syphilis case. Has anyone come across that this year?
Or I'm thinking also what's routine in terms of your STI screening when you're working with someone who's seeking care, whether it's early medical abortion or for LARC.
I'm happy to share. At SHV, we get quite a few syphilis cases, mostly in men that have sex with men, but seeing a few cases in women as well. Often they're being referred through GPs with results and with a pretty unclear history around previous syphilis infections. So I think often people will kind of see a reactive result, think it's active syphilis, and kind of refer them into a more specialised service than very, broad speaking. So it's just really tricky without previous syphilis results to be able to identify whether it's an early new infection, whether it's an old infection. So I know that other states and territories have a syphilis register, which I think would be fabulous. But we've found our public health units really useful in trying to chase down some previous syphilis results as well. So that's been the Southeast Public Health Unit, shout out to them, because they've been really helpful with people that actually didn't need retreating. It was just a previous infection that was detected.
They'll do that sort of.
They can help. Yeah.
Oh, that's good to know. Yeah.
But we're routinely doing it on our early medical abortions, as well as considering doing it as syphilis and an HIV test when we're doing the HCG. So that's pretty, but not doing it, I think, routinely for other like LARC appointments. So that's something I'm writing down to take back to. Yeah, thank you.
And Paul has just joined us. Welcome, Paul. We're just talking about syphilis and the increase of incidence of syphilis in both congenitally and in women who are in their fertile years. And your partner in crime was going to give us a presentation from one of the cases that you had, but she hasn't been able to come tonight. Kath hasn't been able to come. So I just wondered if we're just sharing cases that we have seen, and I was just talking about a presentation I was at recently. Have you got any cases that, to your knowledge, of incidental finding or?
Yeah, complete disadvantage. I'm not aware of what Kath was plotting. I mean, we've certainly seen 2-3 cases this year, which I haven't seen before, apart from once in South Africa many years ago. And then I think the issue might have been, if it's one I'm thinking of, where there was the titer wasn't really falling, which suggested the treatment had failed. But I think the discussion in the end was, no, it probably was successful, and not to worry, but just to keep an eye on it. I don't know if that was the one, but yeah, we've certainly seen 3 cases. But that's all I've got. Sorry, I just got back from England last night. So
that's okay. That's okay. We were just making the point that we need to all be thinking in terms of in terms of antenatal care, but in terms of women who are at risk of pregnancy and are coming across in terms of contraception.
Sure. I mean, certainly the guidelines changed in terms of the antenatal care, retesting again at 28 weeks routinely.
Yeah. So they were presenting several cases in New Zealand where it had been missed, the 28-week being missed, and cases of congenital syphilis have been discovered. What about up in Mildura, Ian? Are you aware of any increase in numbers of cases or?
Well, last year we had 2 congenital syphilis. And I know this year I've actually got 1 who's been treated, but we routinely screen them at their first antenatal visit and then at 28 weeks.
Yeah.
And we've picked up a couple that have converted between the early screening and the 28-week one.
Well, that's good that you've picked them up.
Yeah. Pick them up at 28 weeks, yep.
Somebody else was going to say something, I thought, just then.
Oh, it was just Kylie. I guess generally, I know that Asham are doing a antenatal syphilis train the trainer program. I think it's a pilot program to try and upskill people that are working in that space to then kind of, I guess, share knowledge and do training with colleagues as well. And I think
Sorry, Kylie, could you repeat that for everybody? Who's doing the training?
ASHM.
ASHM, yeah?
Yes, yeah. So I think they've got an expression of interest open at the moment, and they did a pilot this year. So anyone who is an antenatal care provider, I think it's a train the trainer program around antenatal STI screening, but they're focusing on syphilis as well.
Okay.
I'll see if I can share.
That would be great. Yeah.
Yeah. Yeah, so they're doing, I think they ran it this year. I was speaking to someone at Children by Choice, and they said they'd already run one session this year, and they're going to repeat it again in February.
Mm-hmm. If you could share the link or share the contact, that would be great.
Will do.
Yeah.
Because something's come up, but that was last updated in 2021. So
yeah.
I suspect that's not what you're talking about. Yeah.
Well, that's interesting. Thank you very much. And so we might pivot now to giving people an opportunity to either tell us something specific about your area or throw out any ideas in terms of what might be a priority for next year for us as a community of practice. And just maybe to give a little bit of context, just to tell you, for those of you who aren't aware, the kind of requests we've been getting this year have been a lot more requests from the hubs that are a little bit more established. So you're all aware there's now a tranche of 20 hubs with the possibility possibly of some more hubs being released, which is good, but that not all hubs are in the same not all hubs are at the same gestational age, to use a very worn metaphor, sorry. So some of the hubs are really well established and are actually training other practitioners themselves, and others are just getting established. But what we keep getting asked for and are more and more happy to provide now is on-site training for IUD insertion for GPs and for nurse practitioners, so that the practitioners themselves don't have to travel to Melbourne to do the training and come for 4 or 5 sessions, but can get a group of patients together and we'll come and support them. And we're finding that the insertion rate is higher than if they'd come to the city. The patient satisfaction rate is higher and the pain scores are less. So we're thinking that this is a really good little model to keep rolling out, and we're happy to do that with others. And the other thing is more and more interest in pursuing very early medical abortion. So Paul's group in La Trobe are definitely pivoting to that. And that came out of, I think, the background being that the pandemic cohort studies showed that very early medical abortion was safe without ultrasound scan, and that we could really minimize the amount of investigations that we needed to do prior to administrating methane miso, and looking at simplifying our follow-up. So it was a much more patient-centered, patient-delivered service, and that this had an equivalence in terms of safety. We weren't missing ectopic pregnancies, patients weren't hemorrhaging at greater rates, etc. And so because that, when we're talking about very early medical abortion, we're talking about less than 6 weeks, actually, and that can be accompanied by not doing an ultrasound scan. If the patient is certain of their dates and there's a beta HCG done before and follow up rigidly, strictly afterwards for the patients, that this can be delivered very safely. And so we've now extended that to look at it in rural and remote areas. And the couple of groups doing it in this community of practice are finding that it's very safe. So we're getting more and more requests to come and sort of midwife that into the next hub, if you like, so just reassure groups. We're working with Peninsula Health at the moment to get their protocols up and running. And I know that they have got a lot of support from Kath and Paul in terms of what they have done. And then the third thing that we're getting requests for is training for ultrasound provision. And this again has been driven by the fact that ultrasounds are very expensive in some areas, and the waiting time is very high and results in an increased gestational age. So those are the sort of three big things that we've been asked about. Oh, and there is a fourth. The fourth is increasing concern about obstruction by conscientious objecting practitioners. And we've been asked to have a presence in a couple of meetings so that we can help teams that are starting to establish, work out ways to work around the objecting colleagues that they have either in general practice or in the hospital settings to make it easier for the patients. There's one area that they shared with us yesterday at our meeting that we had. There was a hubs meeting with the Department of Health. There's one area where someone from the PHN was saying that the vast majority of the GPs in the area who are otherwise supplying good services are objecting and actually at times obstructing, and that he's in an ethical dilemma about whether or not to report them all to APRA, because then he would lose their otherwise adequate services. And we were just talking about a way of trying to work around those people so that they find it easier to not have to face this ethical dilemma for themselves by making it obvious on their practice websites and their advertising to the patients what they do and don't perform, so that patients aren't being obstructed, and we're getting direct advertising to patients about the 1-800 My Options resource. But there are some areas in Victoria where this is really a major problem, and the only I'm also thinking of Robinvale, actually, Ian, where I was recently involved in looking after several patients who'd been told that abortion was illegal in Australia by the GPs that were there. And then that led to huge increases in their gestational age, so that we ended up seeing them after 24 weeks. But these are people who are really struggling.
So did you say that's Robinvale?
Yeah.
So how long ago was that?
Oh, it was about 3 or 4 months ago.
So a woman had been told termination early pregnancy was not available.
Correct. Yeah.
Okay, I'll follow that up.
Yeah, I have also followed it up. Yeah. I'm happy to talk to you about it. Yeah. Yeah. So she eventually got a service with us after someone was able to tell her about the Sunraysia hub.
There's a clinic in Mildura that does it.
I beg your pardon?
There's a clinic in Mildura that does termination.
Yes, but by the time she heard about that, she was 24 weeks.
Oh.
Yeah. So she came to us. Yeah. So it's and this is a person who's a fruit picker and shares a phone with 6 other women, so not an easy patient, not someone with a lot of agency. So it's not just there, it's not just your area. There's quite a few little pockets where the things that we're hearing from patients are really tricky.
So just in relationship to doing ultrasound, at what gestation or assumed gestation would you want to do an ultrasound before you did a medical termination?
So if the patient had a gestational age that wasn't certain, you'd want to date it.
Yeah.
And you'd want to cite it if they had pain or any other symptoms. If their beta HCG is less than 1,000, there's an expectation you're not going to see a SAC
Sure.
anyway.
Yeah.
So there's some really clear guidelines about very early medical abortion.
So HCG 6,000, what are you going to do?
Sorry?
If the HCG comes back at 6,000, what are you going to do then?
So I would find out what the gestational age was from the patient's menstrual history. And so there are quite a few protocols now developed where if the patient's certain of their menstrual history, so many of our patients track their menstrual histories, and she put it anywhere between 5 and 7 weeks, you could prescribe mifepristone and misoprostol and follow it up closely. You wouldn't necessarily have to do a scan.
So you're a little bit more reassuring as far as women and their menstrual history is concerned.
Yeah, but there is a way of making sure that you've got a good menstrual history. It's not just, do you reckon it was then? It was like, what was that period like? If the patient hadn't had a previous ectopic pregnancy, anyone with a previous ectopic pregnancy, and these protocols are always scanned. But this was Britain, Ian, in the pandemic.
Yeah, sure.
30,000 patients, and they had the same rate of ectopic, whether they scanned them or didn't scan them. So taking a really good menstrual history, I've always thought, is the most basic skill that you learn in ONG.
You must have a different clientele to what we got. So they don't have very good menstrual history.
Yeah. And so if somebody doesn't know, so for example, if the patient from Robinvale came and really didn't know, you would do a scan, you put your hand on the abdomen, you think that's not under 9 weeks, and then you do a scan.
Sure.
Yeah.
You wouldn't feel it in the abdomen at 9 weeks. But anyway,
yeah,
just a protocol that you're developing. I mean, if I'm going to do medical terminations, I need to make sure, A, that they're pregnant, that it's intrauterine and not ectopic. And then up to 9 weeks, I'll be quite happy to do the MS2 step. But so as I said, I work with Broken Hill. I'd probably do 2 a week from up there, and they all get scans, and then they get it probably doesn't cost them anything up there. They get a scan at 10 days to make sure it's complete.
So every place has got different resources.
Oh, sure. Yeah.
So it sounds like you've got quite good resources at Broken Hill, which is good, but there are other places where it takes.
I recognise that.
Yeah. So Paul, did you want to make any comments about how confident you feel about screening patients with regard to their probable gestational age?
Look, I think it's probably along the lines of you talked about the same thing. If you've very good menstrual history, and they're defined reliable, but you get a sense, don't you, that they know what they're talking about, and a lot of women certainly seem to know very well. I guess we've got a bit of a liberal approach to it, and as long as they meet criteria, and there's no history of ectopics, and there's no significant number of cesarean sections and all those other bits and bobs, then we just tend to get on with it, and avoid this issue of people going away and never coming back again, turning up at 24 weeks, which you touched on elsewhere. So I guess, and certainly we haven't had any problems. As you know, we're going to do that study, and was it 500 odd? You said, and it'll be interesting to see the figures at the end of that. But at the moment, that's kind of what we're doing, and it's working well. It's working well, and we've got the option to scan in clinic as well if needs be. Certainly, if there's real uncertainty with the menstrual history, sure, we'll do it. But a lot we're not bothering.
And I would want to stress, Ian, that this is not prescriptive. Everybody doesn't have to be doing very early medical abortion, but it is happening because of lack of resources and patient demand.
Look, I totally agree with that.
Yeah.
I was on the working party of the college in the very early days when MS2 was coming in, and one of the things that the college was concerned about was the possibility of having ectopics, and that people had to have an ultrasound done to exclude ectopics. So we're talking about, I'm not sure when MS2 became available, but probably early 2000 or 2010. But anyway, that was their approach to it, and that slowed things down from a college point of view of agreeing to accept MS two-step. But things have moved on now, and I'm quite happy to provide the service up in Broken Hill. Not quite sure what they do here in Mildura because I'm not involved in that. Now, it's not mandatory that you have to have an ultrasound and sort of stuff, but if you want to err on the worst thing that could happen is you do an MS two-step and someone's got an ectopic pregnancy and they're out sailing in the middle of the ocean and bingo, you end up with a maternal death. Very unlikely, but it still happens. When you look at the maternal mortality, there's a significant number of people who die in early pregnancy from ruptured ectopic pregnancy.
Yeah. So you've got to be sure that you're happy with your assessment. And
I'm sure, yeah.
Yeah. And so I completely take your point that, you may be looking after a demographic where they're not certain of their menstrual histories.
Oh, yeah.
Does anybody else who works in Metropolitan want to add anything? Angie, do you see patients requesting it?
Sorry. Yes, we do.
Yeah.
So we're a big practice, and we now have 5 GPs providing MTOPs, and I do the IUD insertions. I don't think we've moved to VEMAs yet. I think it'll happen.
But you're having patients requesting them, do you think?
I think so, yeah.
Yeah. Because they've sort of diagnosed their pregnancy so early, and I know that the Frankston group were getting the Frankston Hub were getting really frustrated because they had patients coming who diagnosed their own pregnancies really early, and then they would get a scan and the scan would say it's too early to tell whether this is intrauterine or not, and then they would make them wait another 2 weeks, and then they'd have another scan, and when you're just really making the process more painful as opposed to what it would have been when their beta HCG was 900 or something, yeah. So
I was just going to ask, Angie, given you've got that many providers within your practice setting and you feel that it will come eventually, what will shift it in your practice setting? What are the conditions by which you would start prescribing VEMA?
Yeah, it's just personal preference. I think, the more that you're doing in Sexual Health Victoria, the more it becomes normalised. I think because there's so many of us doing them, it doesn't mean we get a lot of experience individually. And so maybe that also needs to change, just the numbers.
Yeah.
Any of the nurse practitioners want to make a comment on it?
Louise, we believe in you. We believe that you can be connected.
We see you. Oh, but we don't hear you.
You're mute. You're mute.
I know. It's funny because you go on and off mute. I don't know why.
Oh, what a shame, Louise, because you just have something good to say.
Yeah. One of the stalwarts in the hubs. Ben's come on board too, and Cara.
Yes, good evening, Ben. Good evening, Cara. No, Louise is. Yes, I do know that Louise is a nurse practitioner, is prescribing.
Yes. Doing many.
Yeah. Any other comments, or we could now just ask, in the closing minutes or so, if there's any those I talked about those 4 kinds of requests, and then just maybe tying into what you said, Angie, if a practice or a hub or a group of practitioners wanted to get together and have a webinar with us about VEMA, for example, or about pathways to ultrasound, or about dealing with colleagues with conscientious objection and how to have conversations about setting up a service, we're happy to do those things. Does anyone else have any suggestions about other things that they would like to see us doing in the next year? Outside of this forum, obviously.
It's Lou trying to get out and then again. Oh, poor old Lou. Any success?
You could put it in the chat, Lou.
Put it in the chat.
Lucy's going to put it in the chat.
Oh,
Angie, I'll put you on the spot again because I know. Angie, what about IUD provision in general practice? So, you know, what do you think about what will get more GPs inserting?
I think it boils down to money, Patty. It's just not financially worthwhile. You have to be very careful with Medicare, and you know, if you're trying to co-bill and charge an out-of-pocket fee, and you know, I'm not the only one of my colleagues who's trained, but nobody else is putting their hand up to do it. I mean, because you have to see all the pre-IUDs and then all the problems afterwards, and it's time consuming. So that's I mean, a lot of them don't even do implants. They don't want procedures. They don't want things that take time. So you have to have special interest.
Yeah.
I'm not sure whether it happens at the moment, but the medical defence payments increased if you're procedurals.
Yeah, that's
right. Which involve putting IUDs and that sort of stuff, which may be a reason why GPs aren't particularly keen to do it.
It's now covered under non-procedural for G IUD insertion, but I'm still not sure about cervical polyps. But anyway.
And I really take your point, Angie, and that's one of the reasons that we have pivoted to really trying to train practitioners at the hubs and nurse practitioners, because we can look at other you know, some of them are salaried, and then we can look at, you know, part payment through the MBS, knowing that it's imperfect, but they can recover some of the costs elsewhere. But the private practice model is really floundering because it's the lack of Medicare, and we are advocating federally about the Medicare items all the time, with a little bit of traction and a little bit of hope recently, but you know, we can't count our eggs till they're hatched, can we?
It's certainly better than it used to be.
Yeah, it's a bit better than it used to be, but that's why we're sort of focusing on the hubs a bit more in terms of training. And we noticed that at the women's, we noticed that quite a few doctors would come and train, but they wouldn't actually, in practice, start putting IUDs in because their practice managers might have discouraged it, you know, or it wasn't financially viable.
But I agree with Angie in terms of the remuneration, and it's a bit of a philosophical outlook. You say, well, I'll do it, but I'm not going to make a lot of money. From my point of view, end of my career and being salaried, it's made a huge difference where you don't tend to think about this a huge amount, but it's still got to be a viable practice. I think that actually sort of centralizing things a little bit, I use the word advisedly, not metropolitan wise, but in certain areas is, I think, quite a good idea. So I guess we, you know, in Morwell at the hub there are trying to, I can do the trainer stuff with the IUDs. Spoken to a couple of my colleagues who are actually quite interested, and I guess getting people together in a relatively small area, which the Latrobe Valley is compared to other parts of rural Victoria, then that might gain some traction. But it's in its infancy, and I think, you know, it's like all these things is the more you do, the better you get, the more confident you are. The post care as well, where that's it, don't worry about that, I've seen that before, as opposed to I don't know what I'm doing, I'm worried, and what happens if this happens. And having colleagues to lean on, I guess that mentoring, isn't it, is very important. Provide that backup. So hopefully we'll be in a position, certainly as the year goes on, so not this year, next year, to provide that. But yeah, it's a complexity. I think certainly leaning, having said that, if you get better rebates, you then get a few more people doing them. But you've got to keep your skills up, and you certainly can rapidly de-skill by not doing them very often. So it's a little bit of a doing the right amount and sharing the load as well. Interestingly, we suggested at our local hospital that we perhaps could do some of their routine IUDs and ease the pressure on the gynae list, and that was met with a resounding silence.
Oh, that's a shame.
That's a pity, because I know that's that Lou, who's having trouble, but put some messages in the chat. I know that the hub have got an arrangement with the hospital, and Ben's here also, where the hub service will take on all of the low risk IUD insertions to free up some space on the hospital-based list.
Yeah. So this is interesting, isn't it? Where, we're talking and are very comfortable with all of this idea and suggestions, and but there is certainly a lot of people out there who are very intransigent and set in their ways. And what does it take to change that thinking, and devolving some of this stuff to the experienced general practitioners who we know can provide a good service and do. It's a bit frustrating, but anyway.
Well, I think that's, one of the strengths of the Victorian model is the hubs model. And because these are medical alternative funding streams that can be doing a lot of procedures, a lot of MTOPs and then a lot of IUDs. And then you get to that critical mass, and then you can become the local champion. I had one quick question for you, Paul, and then we'll take Sarah's question. Could you tell people a little bit about the Train the Trainer? Was it a useful course that you did, or did you do
look, very early in the is it Sexual Health Victoria, was it? I think. Yeah. Victoria. So I did the chat online. I paid my money. I'm just going to get someone to train now.
Oh, I see. So was it all theoretical? You didn't go.
It was all theoretical at the moment.
Oh, okay.
It wasn't anything that I wasn't aware of. It's just I've got to have that bit of paper to now do the next bit to send in the logbook, etc., etc. So I guess we'll see.
Okay. Well, we'll bear that in mind, because we get requests from practitioners all around Victoria, and rather than someone travelling up to us, it would be good if they could come to
that's right. And I think it's a great idea. I think decentralising it is excellent. It's just, I think it's probably making enough people aware of it. And so I've got one colleague who certainly pricked her ears up when she heard. So hopefully it'll develop. Yeah, and more out there with all the issues that Angie's talked about that will encourage people to do it.
Sarah, you had your hand up and then it came down.
Yeah, thank you. I'd had a question. I know other states, registered nurses are able to do IUD insertions. Is there any move for Victoria to follow suit, rather than it being a nurse practitioner, doctor only procedure?
So is that the case in other states?
So I know in Queensland, the nurses work to different scopes of practice. I guess there's medication, nurses can be medication endorsed to prescribe, and I guess it's so different, it is different to in Victoria. But is there any thinking about the hubs and thinking that there's so many on the ground now, and there's a lot of nurses that are in those hubs, from my understanding, quite light on doctors in some of them, whether nurses are being considered for being IUD inserters?
My understanding is that there's nothing to stop nurses and midwives from putting their hand up to become an IUD proceduralist. And as you say, there's scope within the hub workforce. I think it's just more historic that it's nurse practitioners. I don't know of any, Carol's got a hand up, I don't know of any.
There's no legislation against it, though.
Yeah, I don't know any midwives that are IUD prescribers. Maybe there are in private practice. But
yeah, I just think it's an interesting, the nursing workforce is quite large and very competent, and a cheaper resource, I
Yeah.
think. Yeah, it's just something, and yeah, it's not something we do as an organisation, training registered nurses, but I'm always curious to push the envelope to see what more we could be doing.
Yeah.
My feeling is more historic than.
Yeah, I think it is. Cara, you probably have
I think, yes, I worked at Sexual Health Quarters in Perth, equivalent to Sexual Health Victoria, and there were nurses. There was one in Broome that came down and did her training, and the GP was supporting her in general practice. The only reason RNs weren't inserting them in our clinic was insurance. So the insurance body that had the clinic said that a doctor had to be in the room at the same time. So that made it pointless.
So you couldn't have two nurses. Yeah.
That's a battle for another day, I think.
Yeah. Well, I always share with everyone that it was the family planning nurses in Glasgow that taught me how to put in IUDs, and they were amazing. They were truly amazing. So there's nothing to stop nurses doing it. Yeah.
Patty, can I ask just very briefly, and I'm sorry, it's Ben. I'm sorry if this is a naive question, but for GPs in Metro Melbourne, what training options are there for IUD insertion if it's not available, like if it's not taught within the clinic itself?
If it's not taught within the clinic?
As in other than clinics that are doing lots of them and one GP in the clinic is training another GP. Are there other options for people to become trained?
Yeah, they can make inquiries at any hospital that does have an IUD service. So at our hospital, we have one clinic a week. It's the Thursday afternoon clinic is our training session. But we're also looking at having a concept like a flying squad who could go to like say there's a co-health team in Collingwood and there's 4 of them want to learn and they've got a room. We could maybe run a week-long session or something like that.
Yeah, okay. Yeah.
But they are really quite limited. Yeah.
That's one of the limitations, yeah.
Thank you.
So we've got to 7 o'clock, and thank you all for your attendance. Apologies about the case presentation, but we managed to talk a bit about syphilis and how important it was anyway. This is our last meeting for the year. Kath, when's our first meeting?
We haven't worked it out.
We haven't worked it out.
No.
Yeah. It will be February or March.
Yeah.
Yeah.
That'll be good.
Yeah, and we'll be in touch. Oh, there's Serge back again. Hello. Yeah, so we'll work out the dates and we'll send them out.
Yeah, I can email it out to everyone what the dates are in coming weeks.
Yeah, and if anyone has a topic, please be proactive and just let us know. Email Kath with something that you're interested in or want more on. For example, the conscientious objection thing, we could run a webinar on that for the next one if people are interested. Anything, just let us know, or case histories are always good. We always learn from each other. And in the meantime, thank you again, all of you, for the work you do. It's great to see you all here, and we'll hopefully all have a pleasant summer. And
Have a good Christmas.
Yeah. We'll see somebody soon, but have a good Christmas.
Thank you.
Bye-bye. Good to see you, Paul.
Amen.
Bye, everyone.